Hi, my name is Candace Johnson. I'm here to present a clinical case study regarding a small bowel obstruction and a partial colectomy. The goal in this presentation is to inform you of the clinical recommendations for nutrition for both a small bowel obstruction and the partial colectomy. So, an introduction to the patient in the case. WF was an 88-year-old male, Caucasian, admitted to the hospital for abdominal discomfort and nausea and vomiting that he had been having for 4 days. He does have a past medical history of GERD, or gastroesophageal reflux disease, prostate cancer. He had tuberculosis in 1955. He had just had some skin cancer removed from his nose a week before this admission. He has hypertension and diabetes type 2. He does not smoke. He used to, but he does not currently drink any alcohol. He has had a cholecystectomy, so he's had his gallbladder taken out, and he's had a hernia repair in the past. And he also had a normal upper GI study back in 2012. A timeline of the events for the admission. There were 2 admissions, so for this admission, he was admitted from a different ER. He was directly admitted. When he came to the ER, he was given IV fluids and an NG for suction. When he was brought in, they had already assumed, based on the ER notes from the outside hospital, that he had a small bowel obstruction. So he was kept NPO, and he was advanced to full liquids 2 days later. At that time, when he was advanced to full liquids, a referral was made to the dietitian for unintentional weight loss and a non-healing wound to the face. Even though it had just happened, we still received the referral for the wound. When we saw him, GI had cleared him to advance, so we went ahead and advanced him to a low fiber and a carb control diet, and because his sugars were pretty high. We also provided some fiber and fluid education at that point. He had a bowel movement the following day, and basically he was discharged pretty quickly after that. 4 days after that discharge, he was again admitted with more abdominal pain, distension. He had hyperactive bowel sounds. They went ahead and put him on a clear liquid diet, and they ordered a GI consult. The next day, he developed a fever, so they went ahead and started some IV fluids, and they did a CT in the ER before he was directly admitted to the hospital, and those came back showing that there was a malignant obstruction due to thickening of a mass in the cecum. So from there, they ordered a colonoscopy, and they found a mass of the ascending colon and diverticulosis of the sigmoid colon, but they did not find any diverticulitis at that time. So he continued on a carb control diet for a couple more days. He didn't have very good intake, so we went ahead and ordered a nutritional supplement because he was just having trouble consuming foods in general. At that point, he was waiting for discharge to a rehab facility. He was waiting for a bed, but his status quickly declined. He started vomiting, so he was downgraded to an NPO, and then they planned to do a hemicolectomy in the morning. When they did surgery, they found locally advanced right colon cancer with omentum and peritoneal implants, so it had spread to the omentum and the peritoneum. So they went ahead and did a right colectomy, an appendectomy, a right omentectomy, and they also biopsied the peritoneum. After surgery, they put in an NG for suction, and they transferred him to the ICU. He did develop an acute kidney injury, so he was treated with IV fluids. Also, when he was transferred up to ICU, they redid a skin assessment. Whenever they transfer between floors in the hospital, they recheck the skin assessment, and they found 2 stage 1 pressure ulcers on his coccyx and his buttock. So 3 days after his surgery, his acute kidney injury had resolved, so they took out his NG. They transferred him out of ICU, and they had to involve speech. So the speech language therapist went ahead and did a bedside swallow eval. She cleared him for thin liquids, so the GI and the surgeon went ahead and advanced him to liquids. He tolerated the liquids really well, so the speech therapist did another bedside swallow eval for foods, and she recommended a dysphagia 1 pureed foods. He was really groggy, so he wasn't able to advance as quickly as we had liked. That following day, he was appropriate for regular foods after her third intervention. His glucose was really elevated still, but he had only been consuming maybe 51 to 75% of meals, and he was receiving a low dose insulin coverage. So his glucose was high, he wasn't consuming a lot of foods, and he was on very little insulin at the time. The attending physician, the internal medicine physician, went ahead and ordered a carb control diet, and she cleared him for surgery pretty much immediately. We didn't have a chance to reassess the patient before he left the facility. So the pathophysiology of a small bowel obstruction, there's 2 different types of obstructions that can occur. There's a functional blockage and there's a mechanical blockage. A functional blockage is something that's more related to nerve damage or decreased motility. It can be from medications or different surgeries that have caused a lot of scar tissue. Or there can be a mechanical blockage, and this is the one that the patient had. He had a physical blockage. It can be from a tumor, it can be from a volvulus, which is where the intestine gets twisted. It can be from an intussusception, which is a collapse of just a little part of the intestine, or a hernia, or something like Crohn's, or another form of inflammatory bowel disorder. So once the bowel gets obstructed, fluid starts accumulating and it causes a bulge, and then additional fluid accumulates, and then the peristalsis of the GI tract slows down. So you're not getting those waves trying to push the obstruction out anymore, and then it just, sits there. Then the patients usually develop diarrhea, gas. A lot of times they'll develop nausea and vomiting, and then pressure builds, and it decreases the absorption of fluid and electrolytes, and it can create an electrolyte imbalance and volume depletion. If it's not taken care of, it can lead to sepsis or short bowel syndrome or even abdominal abscesses, depending on the cause. If it's more of a mechanical blockage, especially volvulus or intussusception, those will typically require surgery. In the case of this patient, since it was a mass, he required, eventually, at this point we didn't know that it was a mass. We just thought, it was a small bowel obstruction that was resolving. So at this point we just thought it was resolving on its own, but then at the readmission he required surgery. So the pathophysiology of a partial or hemicolectomy, usually they remove the right side of the large intestine, so this part right here. They typically remove the cecum, the ascending colon, the hepatic flexure, and then the first third of the transverse colon, which is this long piece here. And then part of the terminal ileum or any other affected tissue. In the case of this patient, again, they had to remove the appendix, they had to remove the omentum, and then they also had to do some other biopsies. So the large intestine, again, is responsible for a lot of absorption of fluid and other nutrients, sodium, potassium. So when you remove that part of the colon, it puts you at increased risk for deficiencies. So some of his other pertinent medical problems, his diabetes usually was pretty well controlled. Just a brief definition, it's elevated blood blood glucose resulting from defects in insulin secretion, action, or both. Just depends on the, you know, what's wrong with the insulin. Again, normally he's well controlled. He only took oral medications on an outpatient basis. So the relationship to his bowel problems at that point is when your glucose is elevated, it can cause gastroparesis, which can cause further decreased intake and, less nutrient utilization and dehydration. He also has hypertension, which is persistent elevation of arterial blood pressure. Usually it's regulated by the kidneys. Since he was dealing with an acute kidney injury, that was much more difficult to manage. A lot of times blood pressure medications can affect the GI system, so if he's trying to take blood pressure medications on top of dealing with his obstructions and his colectomy, it was going to be kind of difficult for him to manage. So he actually received a clonidine patch instead. It's helped control his blood pressure, and that way he didn't have to take any oral medications for it. So when you have the colectomy, it can cause decreased absorption of fluid and potassium and sodium, and then that makes the blood pressure even more difficult to manage because you're taking away part of that colon where you're absorbing those nutrients that are important for controlling blood pressure. He also had GERD, which is reflux of the gastric contents into the esophagus, which causes heartburn and, pain, and it can lead to erosion. Sometimes it can lead to a decrease of the quality of intake, so patients will a lot of times just consume foods that make their pain decrease, which aren't necessarily always healthy foods, and it will a lot of times lead to a decrease of quantity, so they'll be eating less. It also, depending on the medications that they're taking, they will suppress the stomach acid, so they're not absorbing their nutrients as well as they should be. If left untreated, it can lead to Barrett's esophagus or even esophagitis. He was treated with a PPI, which does decrease the gastric acid secretion and can slow the digestive process. He also had a cholecystectomy, which is removal of the gallbladder. It's recommended in patients with severe cholelithiasis, which is gallstones, and cholecystitis. Instead of the bile flowing into the gallbladder, it goes directly into the intestine, which does make the breakdown of fat and fat-soluble vitamins a little bit more difficult. Eventually they form a pouch where it acts as a gallbladder within their large intestine. But the recommendations are to avoid fatty and greasy foods. Usually they should consume smaller meals at more frequent intervals, similar to a diabetic already. And then they should slowly increase their fiber after the surgery to something that they can tolerate. An acute kidney injury, it's previously been known as an acute renal failure. Depending on the physician, you'll hear both terms still. But it's a sudden reduction in the GFR, or the glomerular filtration rate, and basically the kidneys have a sudden drop in their function and they're not able to get rid of that metabolic waste as quickly as they should be. Usually the patients are not urinating, so they're oliguric, and so you have to pay a lot of attention to their electrolytes and fluids. But on the other extreme, if they're vomiting a lot, if they have a lot of NG output, you may have to treat hyponatremia or hypokalemia because they may have a lot of output. So too much or too little potassium, in short, can cause a short in your electrical system, causing heart malfunction, and your muscles aren't able to contract.